Hello, and thank you so much for joining us today. My name is Mayur Chandrayani, and I'm a senior consultant at Health Management Associates. In partnership with the California Department of Healthcare Services, or DHCS, I'd like to welcome you all to our very first webinar in our Assertive Field-Based SUD Services webinar series. On this slide, you can find a list of commonly used acronyms throughout the presentation. Please feel free to reference back to this slide throughout. I'd like to now hand it over to my colleague, Charles Robbins, who will be introducing himself, along with our other colleagues, Helen and Nai.
Thank you, Meyer. Hi, everybody. My name is Charles Robbins. Before I do an introduction, I'm just going to piggyback on the series. There will be anywhere between 10 and 15 of these webinars with deeper dives in all of the various topics. All right. So again, Charles Robbins, I'm a principal with Health Management Associates. For 30 years, I worked in the community-based organization sector. My behavioral health experience included being the CEO of the Trevor Project, National Queer Suicide Prevention Lifeline for Queer Youth, and worked at the Village Family Services in Los Angeles. I am a person with lived experience. I've been in recovery from substance use disorder for 34 years. I'm going to turn it over to my colleague, Dr. Duplessis.
Good afternoon. I'm Helen Duplessis. I'm a physician principal in the LA office of Health Management Associates. Been here for a little under 8 years and have an eclectic background. My SUD and behavioral health background started many moons ago in perinatal substance use in Los Angeles, California, building programs, training and working with the Department of Child Protective Services here. And I've had the opportunity to build MAT programs in community clinic settings subsequent to that, and worked on several state opioid response grants over the last 8 or 9 years, 7 or 8 years here at Health Management Associates. And I'll turn it over to Nai.
Thank you. Good afternoon, everyone. My name is Nai Kasich. I'm principal with HMA located in Sacramento office. My background is over 25 years of experience working to advance health equity, improve access to care. My work focuses primarily on operational improvement, technology-enabled solutions, and program design. I also bring in 20 years of executive leadership experience working at Medi-Cal managed care health plans such as LA Care and HealthNet. And I do bring in expertise related to program development, community and provider engagement, quality improvement, and health equity. And I'm glad to be here today and look forward to today's conversation. All right.
All right, let's go to the next slide. So our agenda is we're going to start out with a little bit of history and the recent timeline of really a lot of changes that have been happening in the behavioral health system here in California. We want to compare the Mental Health Service Act and the Behavioral Health Service Act, some of those components, and as well as the resource allocation. We'll dive into full service partnership, where assertive field-based initiation of SUD treatment services lives as part of the manual for this initiative. And we'll give you a list of the upcoming webinars and training and have hopefully a little bit of time for Q&A. Next slide. So our learning objectives, we would love you to walk away being able to explain the relationships between the Mental Health Service Act and the Behavioral Health Service Act and the significant transition in how key funding resources are reassessed in the Behavioral Health Service Act. We'd love for you to describe the intention behind full service partnerships, list at least 3 required components of all FSP programs, and list the 3 areas for which counties are required to deliver assertive field-based initiation of SUD treatment services. Okay, let's go to the next. And I'm going to turn it over to Dr. Duplessis.
Thank you so much, Charles. Our work is so ecosystem based, and it's really important for us to have an appreciation not only of what else is in the ecosystem and what other programs are serving our clients around us, but also to know a little bit about the history and some of the things that have been going on. So I'm going to spend a little bit of time on that, starting with this next slide, which is really a very busy slide that we borrowed from the Department of Healthcare Services. And it shows a timeline of the many state behavioral health initiatives that have been developed and are in various stages of implementation across the state. So really, really very quickly, for context, the slide depicts a timeline in that blue arrow. Looking back over the last 5 or 6 years, the top part that has those little colorful postage stamp boxes really highlights at a very high level the critical goals of the high level goals of each of those initiatives. And that bottom part that we'll do a very quick flyover on shows the rollout of those various behavioral health initiatives, starting over on the left with SB 855, which really strengthened in the state of California our parity rules between behavioral health services and physical health, and moving along into 21 and 22, we had the Behavioral Health Continuum Infrastructure Program, lovingly known as BCHIP. That's really a bond established to build and rehabilitate a number of state and additional facilities to expand the infrastructure for the continuum of behavioral health. Many of you are familiar with the Child and Youth Behavioral Health Initiative that's really reimagining behavioral health services for children and youth across the state, and the California CalAIM, or California Advancing and Innovative Medi-Cal program, which we'll talk about in just a second. By the time we got to 22 and 23, we were moving forward with the CARE Act. I think many of you are familiar with the Community Assistance Recovery and Empowerment Act. We'll talk a little bit more about that shortly. And building behavioral health crises services, establishing and continuing our 988 services, full scope behavioral health services in the state of California. And then by 23 and 24, we had begun working on the behavioral health community-based organized networks of equitable care and treatment. That's a mouthful, BH Connect, it's known as. And of course, the passage of Prop 1, which kind of gets us to where we're going today. On the next slide, Prop 1 actually accomplished two significant changes in our ecosystem. The first thing it did was to authorize an additional big chunk of change, almost 6.4 billion in a behavioral health infrastructure bond that will continue the development of infrastructure, supportive housing, community beds, etc., and also a specific focus now on housing for veterans and behavioral health needs of persons who are unstably housed and experiencing homelessness. The second thing it did, of course, was to reframe the Mental Health Services Act, that millionaire's tax that we passed some years ago. We now renamed that as the Behavioral Health Services Act, or BHSA, which added now substance use disorder, so that it's focusing on both mental health and substance use disorder. And it also modified how funds are allocated, expanding the eligible population to those who are unstably housed. And let's go to the next slide. With this behavioral health word cloud, I guess. We really wanted to remind you all that BHSA provides the glue and the strategy and the longevity that should always be considered in the context of all of the other big, hairy initiatives that we have going on in California. And we'll just highlight a couple that we've already seen in our postage stamp slide. Of course, CalAIM is the largest largest Medi-Cal transformation we have ever seen in our state. And it included, of course, behavioral health transformation and finance reforms that are continuing to move forward. Really importantly for the population that we're serving in AFBSS, CalAIM included the development of a new benefit, enhanced care management. So it's case management and care coordination for the most complex individuals, as well as community supports that provide focused housing and additional kinds of support for Medi-Cal beneficiaries. And that enhanced care management, I should remind you all, it's got several populations of focus that overlap completely with the population that we're serving, not least of which are homeless individuals, individuals who have serious mental health and SUD challenges, those who may be justice involved and are reentering, and others as well. And then, of course, as mentioned with BH Connect, we're really increasing and building out that continuum of community-based health services for Medi-Cal members with a variety of different kinds of supports, not least of which are the development of centers of excellence that will provide consultation and additional support for behavioral health providers in addressing the needs of their clients, evidence-based practices, incentives to build out workforce, et cetera. And then you can see in that last bullet some additional initiatives that are going on as well. Some didn't even make it into the postage stamp, including our mobile crisis program, the long-standing drug Medi-Cal and drug Medi-Cal organized delivery system programs that many of you already participate in and contract with. So let's go to the next slide. You know, the purpose and the goals of the Behavioral Health Services Act are really to continue to address the behavioral health needs and reform and modernize how we are doing that, so that we are now including not only the population served before, but our unstably housed and those with substance use disorders and those who have various kinds of systemic gaps. The core goals of BHSA, as I think many of you are aware, are to improve access to integrated behavioral health care. So integration here means a number of different things, including integrating our SUD and our mental health services at the county level, as well as across the ecosystem, and integrating behavioral health with primary care, which is something increasingly we're being asked to do through AFBSS. Other goals include obviously expanding our housing interventions for these vulnerable populations, and then enhancing equity outcomes and transparency. You know, we are really fortunate to be in the state of California, where we are encouraged and even frankly required to continue the focus on building and supporting services that are equitable, that acknowledge and address disparities, and that recognize with humility the importance of building low barrier access to support and meet our colleagues and our clients where they are. And with that, I'm going to turn it over to Nye to pick up and share more about BHSA and beyond.
Dr. B. So we're going to share with you side-by-side comparison between MHSA and BHSA. If you go to the next slide, please. So the significant changes here is that with BHSA, now we're going to be, as Dr. D mentioned, integrate SUD into mental health services. In terms of funding, rather than funding in those 5 categories, now we're focused on 3 specific components that include the full family partnership. Again, FSP no longer will be under community services and support. And the allocation is about 35%. Behavioral health services and support will be about 35%, and the housing intervention that Dr. Duplessis just mentioned. Again, there's some flexibility in these fundings, and so these are some opportunities. In regards to the expenditure reports, so there is a requirement of annual behavior health outcomes, accountability, and transparency report. So these are all county behavioral health funding sources, not just BHSA, but it's going to also include relevant outcomes and also measures for the programs that are managed at the county level. And then in terms of equity, again, we're moving away from general equity language to mandated disparity reduction, seeing stratified data and alignment to population level health goals. Just a couple of takeaways from this is that, again, just reiterating that SUD treatment is funded under BHSA, no longer optional under MHSA. Again, looking at the eligibility of those individuals include moderate, severe SUD, even without mental health diagnosis. And again, for BHSA eligibility, it's aligned with Medi-Cal criteria. And again, individuals do not have to be enrolled in Medi-Cal managed care. And then the last I'll just re-emphasize is the integration of SUD data into the existing mental health system. So there's some really great opportunities here. If we go to the next slide, we wanted to provide a visual of the current allocation of funds. And if we move to the following slide, this is the next slide. This is a current MHSA funding buckets, but as we move forward with BHSA, thank you. As you can see, flexibility in terms of funding allocation to focus on these 3 priority areas. Housing intervention, again, 30% of the budget. For people with most significant mental health and substance use disorder treatment needs who are experiencing or at risk of homelessness, there's opportunities for resources there. We're looking at 51% of the chronic homeless individuals. And so again, support for those needing housing placement, and up to 25% of the funds could be used for building new housing or retrofitting existing housing. And then the next category, the full service partnership, FSP, 35% of the budget. It can be allocated, and that includes a comprehensive and wraparound services that really optimize Medi-Cal billing, strengthening any of the range of services, individuals, families, and community needs. And then the last category is for behavioral health services and support, again, about 35%. And this would be for the comprehensive and intensive care for people of any age with most complex needs through treatment, housing, employment, and other services. I just want to call out that 35% can be directed towards early intervention, and of which 51% can be for early intervention for children and youth 25 and under. The last thing that I will leave you with is that this change really is intended to build upon the current work that you've been doing and progress that's been made. And really, this is an ongoing effort to support the vulnerable individuals living in the most significant mental health conditions and those with substance use disorder. And then if we move on to next, I'll pass it off to Charles.
All right, I'm going to dive into that center circle, which is full service partnership. And so full service partnerships include intensive community-based services for individuals with severe mental illness or severe emotional disturbance, as well as co-occurring disorders. FSP really leverages the whatever it takes approach including counseling, crisis support, and other supports. As Nye had mentioned, FSP makes up about 35% of the funding, and there are some new requirements, including evidence-based models, standardized levels of care, and focus on some key populations. Let's go to the next slide. So FSP has a continuum, and this is, I'm just going to kind of read these off, but we're going to spend time diving into assertive field-based services. But we've got mental health services, supportive services, and SUD services. Assertive community treatment, forensic assertive community treatment, FSP intensive case management, individual placements and supports, high fidelity wraparound, assertive field-based SUD services, our outpatient behavioral health services for evaluation and stabilization, ongoing engagement services, service planning, and housing interventions, which is actually funded under the housing category. Let's go to the next slide. And I'm going to dive into assertive field-based initiation of SUD treatment services. Let's go to the next slide. This slide kind of explains that under the Behavioral Health Services Act, counties will receive technical assistance by HMA to implement field-based services. The focus is on using proactive field-based strategies to better engage people with substance use disorder, as well as to reduce overdose risk and expand low barrier access to MAT services, medication for addiction treatment. These requirements apply to all substance use disorders. We're not just talking opioid use disorder. And counties are expected to actively deploy programs that reach individuals who are currently unengaged in care. On the next slide, so assertive field-based initiation uses a proactive voluntary no wrong door approach to connect people to SUD, to medication, people with SUD to medication. Counties are encouraged to prioritize outreach to populations with higher barriers to care, such as people who are unhoused or housing insecure, those that are justice involved, or have co-occurring mental health needs, and to conduct ongoing targeted outreach in community-based low barrier settings to initiate MAT or other treatments. On the next slide, this gives you a sense of the community-based low barrier settings that are a focus. So the street, shelters, homeless encampments, customer-operated wellness centers, drop-in centers, syringe service programs, medication and mobile narcotic treatment programs, as well as other easily accessed locations to reach people where they are. The idea here is to take our services out and go to the people rather than the people coming to us. Next slide. So there are three distinct areas or categories that counties need to stand up at least one initiative in each of the three areas. That's data-informed targeted outreach, mobile field-based programs, and open access clinics. So again, the three areas, this is the first one, data-informed ongoing, meaning it's not just a one-time thing, targeted outreach. So conduct that ongoing outreach to connect individuals with SUD services, including MAT, and providing mobile field-based programs, open access clinics, and other providers. Doing the targeted outreach services can be performed by new or existing mobile field-based teams, or can be delivered through other models such as case management team. Let's go to the next slide. Again, data-informed ongoing targeted outreach to identify those The state is encouraging counties to collaborate with your EMS, with law enforcement, with managed care plans, health systems and hospitals, federally qualified health centers, rural health clinics, and individuals living or lived experience, as well as other partners to really obtain the data on the regions and to look at the populations with the highest rates of overdose reversals, drug-related arrests, and other relevant statistics on a regular basis, knowing where these individuals are located. Next slide. So the field-based programs are teams essentially to conduct on-the-ground field-based outreach to provide engagement, harm reduction support, trust building, motivational interviewing, and directly provide or facilitate rapid access to MAT and other SUD services. And as and the goal here is to ensure that we can deliver MAT services and embedding some MAT prescribers or referring individuals to prescribers, including the NTPs. So some examples are, street medicine providers, street outreach programs with MAT prescribers, as well as mobile NTPs. Next slide. So for open access clinics, the counties can support open access, which are outpatient settings providing low barrier, low threshold, rapid access to MAT. So you can leverage existing or stand up new brick and mortar programs within your catchment area. And examples include syringe exchange programs with drop-in clinics, medication units, drop-in outpatient clinics with open access scheduling.
Thank you so much for joining us today in our first webinar. We are here to support you, so if you have any questions at all, please feel free to email us at info@afbsstraining.org. Thank you.